Okay, hi. Good morning, everyone, and welcome to Grand Rounds this morning. You'd be a fool to miss Grand Rounds this morning, that's for sure. In case you were wondering, the next time that April 1st follows Easter Sunday is 2086, and if you want to volunteer to give Grand Rounds, see me afterwards, and we'll sign you up. This morning's a special session, as you know. This weekend is the ACC convenes in Atlanta, Georgia, and we have a very strong presence this year. We have 29 abstracts, of which 9 are moderated posters, and we have 7 podium presentations, and we have 5 people who are either chairing or co-chairing sessions. So just a wonderful representation. I know many in this room are going to be in Atlanta. And so this morning we have 5 presentations by our research physicians on various topics, which I'm going to be introducing. First, I'd like to thank Sean from AstraZeneca for supporting this morning's session. So with that, I'm going to invite Dr. Phichaphop up to present the first talk. We enjoy having him from Thailand, where he's a interventional cardiologist with an interest in structural heart disease, and his smile always lights up the room. So Asa, can you come on up, please? He's going to present to us this morning on predictors and outcome of unplanned coronary angiography after TAVR. Thank you.
Yeah, thank you, Dr. Shargi, for your kind introduction. Good morning, everyone. I am Asa. Basically, I'm interventional cardiologist from Thailand, and my work is about coronary intervention and also TAVR. So I'm very interested in how the relationship between those aortic stenosis and coronary artery disease. That's why my talks today will be about unplanned coronary angiography after transcatheter aortic valve replacement in terms of the incidence, predictor, and outcome. I have no conflict of interest. The background here, as you will know that the coronary artery disease and the aortic stenosis, they share the similar pathophysiology related to the atherosclerosis. And then they will always be usually found together. And when the patient has severe AS, when the TAVR prosthesis was implanted into the patient, that will have some difficulty in terms of the coronary cannulation, and also exacerbated when the patient came with the emergency condition like the ACS that need coronary intervention very quickly. This is the coronary angiogram of the same patient. On the left side is before TAVR. The operator can engage the coronary artery very quite nicely. And then after the TAVR valve have been implanted and this patient has been gone through the procedure again, it's kind of hard to do the coronary engagement. That takes longer time, or the quality of the coronary angiogram in some cases is quite challenging and not well visualized. So the objective of my research here is to know about the incidence of the unplanned coronary angiography after TAVR procedure have been done, and also the 5-year prediction model of the needs for coronary angiography. So we will have to find out who will get higher chance of the coronary angiography compared to other. This is the method here. We have included all patients underwent TAVR over 7 years with the procedure success, and the outcome is the incidence of the cardiac cath. We exclude the planned angiography or PCI that was decided prior to TAVR, and also if the angiography is performed at the same time of TAVR, we also exclude. This is the result. Over 1,400 patients with the median time follow-up of 26 months. The mean age of patient was 81 with STS score of 3.4, which is on a little bit lower side of the score. 64 or 2/3 of the patient was used the balloon expandable valve. The incidence here of the unplanned coronary angiography is 6.7% on the red bar. When we look into the indication for the coronary angiography performed, they were performed for acute coronary syndrome in half of them, which is more largely to be unstable angina or non-extubation MI among that 50% of ACS. This is the basic characteristic. You'll be appreciated on the right side on the green color. The patient who has unplanned coronary angiography, over 97 patient, mean age of them are younger than the other groups. They were more male gender, and they were more having the comorbidity like the diabetes. For the coronary artery disease, the patient who has cardiac cath has the higher concomitant coronary artery disease, as well as the prior CABG and also prior PCI. When we look at the patient with CAD compared to those who doesn't have CAD, the patient with CAD have higher rate of the unplanned coronary angiography in the in the green line. They are like 3 times higher rate of the coronary angiography, and that's different persists over 5 years. When we look into the subgroup of the patient who has CAD, the patient with multivessel disease and the patient with CABG, they have higher rate of the cardiac cath over 5 years compared to those who doesn't have. So that means this group is the high-risk group, or the group of people that have high chance of in the future doing the coronary angiography. So that will be the patient who we should take a look or taking attention to. This is the 5-year survival comparing those who have and doesn't have the coronary angiography. On the blue line here is the survival of the patient who have unplanned coronary angiography, and they have the lowest survival from the start and to 1 year and to 5 years, compared with the graph above is the patient who doesn't have the coronary angiography. So we want to know the factor, which factor would be association with the unplanned coronary angiography. This is the unique and multivariable analysis. From here, we can see this 4 factor is important factor for the patient. First is if the patient has low mean aortic gradient from the start, they will have increased association with the unplanned cardiac cath. Second, if the patient has dialysis, they will have 2.6 times higher chance of undergoing cardiac cath in the future. The third, as we all already know, that the patient with significant CAD, here they have like 3 times higher chance of doing the procedure in the future. And the last one is the patient age. The more younger the patient, the more higher chance of them to get the coronary angiogram done. And from these 4 factors, we also do another analysis to create a prediction model, 5-year prediction model. From that model, we kind of pick up the factor that is quite similar to this. And then this 5-year model doing very well. For the calibration part, we can see it's very good calibration. And also for the ROC curve here, we got 0.71 and 0.76 for using that 4 variable and also the LVEF in the prediction model. In the limitation of time, I will go to the clinical application. Considering if the patient has higher chance or risk factor of the unplanned coronary angiography, we should take very close attention, and we should carefully evaluate and attempt to minimize the occurrence of event in those patients. This is the take-home message. So about the unplanned coronary angiography, the occurrence here is 6.6% after TAVR, and ACS was the indication in half of them. Patients with significant CAD have 3-fold higher needed for that procedure. The patient with risk factor, young patient, dialysis, with beginning with low mean aortic gradient associated with higher need, that will be many factors that give rise to the cause of low mean aortic gradient, like low gradient AF or high flow low gradient AS that give the reason to that. So finally, the comprehensive strategy should be taking care who the patient when we think of the lifetime management on this patient after TAVR. Thank you.
we're going to have time for one or maybe two questions after each presentation. So does anyone have a question? Or I'll ask you a question. When you look at the patients who had unplanned angiography, what % of them had a revascularization procedure done consequent to that?
Thank you. That's a very good question. Among 97 patients here, we have 48 patients of the PCI done. So it's 50% of the PCI. And when we compare the patient who has CAD and patient who doesn't have CAD, the patient who has CAD has higher chance of coronary intervention or PCI.
And so if it's 50%, then is there a role for CT angiography as maybe play a role in analyzing these patients ahead of time? What are your thoughts about that?
Yeah, I think that's a very good question. If the patient come with the non-urgent or non-emergency condition, I think there will be a area that the CT should taking into account and or should include in the consideration. Yeah, and because the coronary angiography may be more complicated in those patients. But if in the emergency, we have to go directly to CAT.
Thank you.
Thank you so much.
Okay. Next on our agenda this morning, Dr. Atsushi Okada, who comes to us from the National Cerebral and Cardiovascular Center in Osaka, Japan, and gave us a really nice grand rounds here just a couple weeks ago on left atrial appendage exclusion. This morning, he's going to speak to us on the in-vivo CT sizing for redo-transcatheter replacement in the Evolut Medtronic valve. So thank you very much for your talk.
Thank you for the introduction. It's my pleasure to present about our data on TAVR. So there's two main transcatheter valves that each have different designs. So on your left is the SAPIEN 3 or the SAPIEN 3 Ultra valve, which is a balloon expandable and a short valve. On the right hand is an Evolut Pro or FX from Medtronic, which is a self-expanding valve. And you can see that the height of the valve is different between these two. And now the more patients are receiving TAVR and more patients there's a need for a second procedure, which we are calling TAV-in-TAV or redo-TAV. So just with these two valves, we are having a 2x2 combination, and you can probably imagine that how complex this could be. So the background of my study is how should we plan this TAV-in-TAV procedure? So this study mainly focuses on S3 in Evolut, which is one of the common combinations that is performed in practice. And the baseline is how to decide the second TAV size is not fully understood. In this figure, I'm showing that the recent reports are using a S3 size that is used in bench testing. And these are the size used. For example, S320 is used in Evolut 23, S323 used in Evolut 26, and so on. However, as you can see here, for example, if you look at S329, that goes into a Evolut 34. The Evolut valves always has a waist that narrows down, and the waist of a 34 is only 24. And you can imagine that if you use 29, this could be too large. So the hypothesis here is that, is there a better way to decide the S3 size? And here's our hypothesis and aims. So using a uniform size that used in bench sizing may be inappropriate since one, the Evolut has a waist, and second, the Evolut valve is often underexpanded when it is placed in a patient. And then the second S3 size would impact the feasibility of redo-TAV, or it could change the risk to the coronaries of the procedure. And if it's too large, it may be harm if oversized because it could lead to possible annulus rupture. So the hypothesis is that if we apply a CT sizing, it could be smaller than what is used in bench sizing. So the aim is to evaluate the usefulness of applying in vivo CT sizing using post-TAVR CTs and its impact on TAV size, risk to coronaries, and the estimated risk of prosthesis-patient mismatch. So we studied post-TAVR CTs of 290 patients who underwent TAVR using Evolut R Pro or Pro Plus. And we did a CT simulation of S3 in Evolut in 3 implant positions, which is node 6, node 5, and node 4. This is how we do the CT sizing. We would take an average of 4 areas, which means that the top level at the nail skirt plane or the implant position of the S3 outflow and 4 nodes below and average the 4 areas on CT. And then this average area was referenced to the sizing table of S3 to decide which size should be used. The next step would be to evaluate the coronary risk or the redo-TAV feasibility. So this was evaluated by measuring the narrowest VTA distance, which means we simulate a second valve and the distance from the simulated valve to the coronaries or to the ST junction if appropriate. And here we are using a size of the sapien that we chosen. So if CT sizing chooses a smaller valve, this measurement also would change and consequently will change the risk to coronaries. This is the key result of this study. So when the rates of S3 size when CT sizing was applied was smaller to conventional bench sizing in over 80% of the cases. So again, by bench sizing, S3 size was smaller than the conventionally used bench size in over 80% of the cases in all of these implant positions simulated on CT. And this would lead to our second important result, that the feasibility of redo-TAV or the risk to coronaries is different between bench sizing and CT sizing. And as you can see, that applying CT sizing would always be a higher percentage, which means that the feasibility is higher by CT sizing. So risk to coronaries were lower and means higher feasibility by CT sizing. The last result is about prosthesis-patient mismatch, or PPM. Although that CT sizing indicated a smaller S3 size, the percentage of the predicted severe PPM were minimum and less than 10%, even when CT sizing was applied. So to summarize these results, applying CT sizing for S3 in Evolut resulted in smaller S3 size compared to bench sizing in over 80% of the cases. And this is possibly a consequence of the underexpansion and the waste of the Evolut. The risk to coronaries when CT sizing was applied were lower by CT sizing, which means higher feasibility for S3 in Evolut. Last, predicted risk of PPM was less than 10% by CT sizing. So in conclusion, applying CT sizing for S3 in Evolut increased the feasibility of redo-TAV or TAV in TAV and lower the risk of excessing oversizing and subsequent complications. Thank you.
Questions? Thank you. That's a nice presentation, and it blends nicely with the previous presentation on the coronaries. But do you have a sense, since this seems like it's going to be a fairly big problem going down the road with now that the TAVRs have been with us for a few years, do you have a sense for how many patients per year we're seeing at this institution over the, say, the last 5 or 10 years that now have the need for this valve-in-valve?
So I don't have the exact number on top of my head, but we are really seeing an increased number of cases for considering redo TAV, which means the previous TAVR valve failed, and then the patient comes into us. So I'm sure that a big wave is coming to this.
How does this become operationalized? Are we doing this analysis here in advance? So
Thank you for that point. So it's been about a year since we have developing the redo-TAV app, which is coming very soon. And as we progress these project, we have realized a lot of things that need to be paid attention, which has not been focused so much before. But we are showing a really important sign here that this should be recognized.
thank you.
Thank you.
We're going to transition into the electrophysiology sphere now. Invite up Dr. Ali Bahbah, who's a scholar in the Electrophysiology Science Center and has come to us this past fall from Cairo, Egypt, and has done a great job of working very hard, I know, from personal experience. And he's going to talk to us about cardioversion practices in atrial fibrillation appendage patients after post-appendage left atrial appendage closure. So it's an important topic.
Thanks, Dr. Shorky. Good morning, everyone. So I'm going to talk about direct current cardioversion in atrial fibrillation patients after left atrial appendage closure. I have nothing to disclose. First, I would like to start with a brief background on percutaneous left atrial appendage closure and cardioversion in atrial fibrillation. Left atrial appendage is known to be the source of more than 90% of strokes in atrial fibrillation, and left atrial appendage closure is a procedure that is proposed as an alternative for oral anticoagulation for atrial fibrillation patients. It can be done either surgically or percutaneously, and there are more than one available occluding device for it. And the device that you can see is the Watchman Flex device. It's manufactured by Boston Scientific. Usually, after the procedure, patients should follow the recommended anticoagulation regimen. It differs according to the bleeding risk of each patient, but what I would like to highlight is after 6 months, regardless of the bleeding risk, patients should remain on single antiplatelet therapy regimen, and this is important for the rest of my talk. Direct current cardioversion in atrial fibrillation patients carries a risk for stroke, and in order to mitigate these risks, usually the recommended guidelines are very clear for patients receiving oral anticoagulation, but unfortunately for patients who had an implanted Watchman device, it's not clear what is the best practice for cardioversion. To answer this question, there hasn't been many published manuscripts on it, but the most important one was a study published by Sharma et al. And Jack in 2019. They included 148 patients after the implantation procedure who presented for cardioversion. All the patients in this study had transesophageal echo before cardioversion, and they assessed the safety and effectiveness of cardioversion in these patients. It was deemed safe and effective as they followed up for 6 weeks after the cardioversion. None of the patients had strokes or death after the event, and it was effective as all the patients had restored normal sinus rhythm after cardioversion. But what was interesting is they found almost 3% of device-related thrombus on imaging, and when they went into depth analysis of these 3%, it was 4 patients. 3 out of the 4 patients were on single antiplatelet therapy, and these 3 patients presented after the first 6 months. So on our side, we wanted to explore this specific subset of patients presenting on single antiplatelet therapy after the implantation procedure and also after 6 months. So in our study, safety was defined as freedom from systemic embolism, death, or device embolism within 30 days after the cardioversion event. And we also wanted to look at the feasibility of doing cardioversion without pre-procedural imaging. And this is because there were other manuscripts that showed a wide variety of practices when it comes to pre-procedural imaging in cardioversion in these patients. We looked at all the patients who had a Watchman device implanted in all Allina hospitals from 2016 to 2023. There were 93 patients who received cardioversion, and after applying our selection criteria, we included only patients who presented 6 months after the procedure and were only on single antiplatelet regimen, as I mentioned before. So at the end, we had 46 patients in our subset with a total of 62 events of cardioversions. We included multiple cardioversions for the same patient if it was separated by a month or more in order to be able to assess for the complications. Most of our patients were females with a mean age of 75 years and BMI of 32. It was a high-risk population or subset with a CHA2DS2-VASc score of 4.6, and almost 40% of patients had a history of stroke. Comorbidities were abundant, with heart failure being almost 55%. Chronic kidney disease and diabetes were also abundant. 54 cases or events of the patients presented on aspirin, while the other presented on clopidogrel as a single antiplatelet therapy. And as for pre-procedural imaging, almost 80% did not get pre-procedural imaging, and only 20% had either TE or cardiac CT. And no device-related thrombus were noticed on the imaging, but peri-device leak was very high, almost 30%. 4 out of the 14 patients who received imaging had peri-device leak ranging from 2 to 3 millimeters. Safety endpoint was achieved in all the cases, as none of the patients had a stroke or death or device embolism through the 30 days of follow-up. In conclusion, we can say that cardioversion should be or could be considered safe in patients presenting on single antiplatelet therapy. As for the point of performing cardioversion without pre-procedural imaging, this is still under question because the high rate of peri-device leak is important, as there has been manuscripts suggesting that peri-device leak is directly associated with a higher risk of stroke. So this should be taken into consideration, as it might affect the management of patients presenting for cardioversion, as, for example, delaying the cardioversion event or avoiding it completely. And as a limitation, our study had a small sample, and of course, more studies are needed to find the optimum approach of cardioversion in these patients. Thank you.
Any questions for Dr. Bahbah? So 1,000 patients, all the line of that's commendable.
Yeah.
A lot of work, I'm sure. You know, from your perspective and looking at this landscape, it doesn't seem like we have any standard approach. And I'm wondering if there are any, thoughts in your research group about how to, sometimes when we don't know, it may be best to at least say, okay, we don't know, but this is how we should do it. And then, look at the outcomes based on
So there are two important points: the device-related thrombus and the peri-device leak. As I mentioned, these are the two most important findings that you can find on imaging before doing the cardioversion. As for the device-related thrombus, it's not very clear as whether it's directly associated with a higher risk of stroke. It has been reported, of course, that it is, but for Allina hospitals, a lot of the patients, as I showed, 80% are not getting TE imaging or CCT imaging before the procedure. So I would think it's leaning more towards that patients with an implanted Watchman, it is safe to undergo cardioversion without pre-procedural imaging. But as I said, we can't conclude that completely because peri-device leak is also associated with a higher risk. So it's still like our group is leaning towards undergoing cardioversion without pre-procedural imaging, but we still need more patients to confirm that.
Okay, that's very provocative findings. Thank you for that. Our next presentation will be given by Dr. Ahmed Al-Ogaili, who is the Frank and Eleanor Maslowski Charitable Trust CHIP-CTO Fellow, working with Dr. Balakis and his group in the CTO world, and he's going to speak to us on retrograde CTO PCI via ipsilateral collateral approach.
Thank you so much for the introduction. So today I will share my work about retrograde CTO via ipsilateral collateral. So, CTO PCI remains one of the most complex procedure done in a cath lab, if not the most complex. And in fact, if you look at national success rate from the NCDR registry, the success rate is only 60%, which is extremely low. However, when you look at more experienced centers and more experienced operators like the Euro CTO registry and the Progress CTO registry, you see that the success rate is significantly higher and closer to 90% in these centers. And one of the reasons that this success rate is higher is the expertise in advanced techniques like antegrade dissection reentry and the retrograde approach that is performed in these centers. And if you look at the complexity of techniques that we do, you can see at the far left of the screen that going through an epicardial collateral is the most complex technique. And I would argue that going through an ipsilateral epicardial is the most complex. And this is the case that I would like to kind of share with you to give you an example of the group of patients that we wanted to capture in our study. This is a young man with angina, ischemia in the LAD territory, and you can see his angiogram shows a mid-LAD CTO, and his distal vessel is filled by an epicardial ipsilateral collateral from a diagonal branch. So how do we consent this patient? What are his risks if we end up using this collateral as a conduit for retrograde approach, and which equipment do we use? And just like our patients, other studies have shown that, for example, in RCA CTO, about 30% of them are supplied by ipsilateral collateral. So we use the Progress CTO, which is a prospective registry, a multi-center registry. And we collected all data, all cases that were done between 2012 and 2023. And after exclusion of cases that did not use the retrograde approach, we ended up with about 4,500 cases that use retrograde approach. And then we divided these into ipsilateral collaterals versus all other collateral conduits. And then we compared basically the baseline characteristics and the procedural outcome of these two groups. And just routine statistical methods were used to analyze our database. And if we move on to the results, basically, so what we found is that the most commonly used retrograde conduit was the septal collaterals in 60% of the cases. And this was followed by contralateral epicardial collaterals and then SVG grafts, or a group of interest, which is the ipsilateral collaterals, were only attempted in about 4% of the cases. And if you move on to the baseline characteristics, so the mean age was about 65 years, and then comorbidities were prevalent in both groups. The only difference that we found was in the prevalence of heart failure and dialysis, which was higher in the ipsilateral group patients. Moving on to the angiographic characteristics. So as we expected, the dual injection was performed were less likely to be performed in the ipsilateral group because most of the time you would use a single guide instead of two guides. And then the most common target vessel in the ipsilateral group was the circumflex. And this is because usually the RCA and LAD have septal connections between them. On the other hand, the circumflex is most likely to be supplied by ipsilateral collaterals, either from diagonal or obtuse marginal branches. And lastly, unfavorable anatomy was more common in the ipsilateral group, so more likely to have proximal cap ambiguity and side branch at the proximal cap. And then when we look more at the procedural details, so what we found is that antegrade approaches like antegrade wiring and antegrade and dissection reentry were more likely to be used as the first strategy and more likely to be successful in the ipsilateral collateral group. And this basically tells us that operators tried their best to avoid using these collaterals and only use them when they had to because they probably understood the risk of going through these collaterals. And looking at more technical aspects, so the success of wiring these collateral was only 50%. So half of the time they were not able to even cross the collateral. And then when you look at the equipment that they used the most commonly used wire was the SUO3, which is the softest wire available in any cath lab. It has a tip load of 0.3 grams. And the most likely used microcatheter was the Caravel, which is, again, a microcatheter made by Asahi. It's very soft, small in size, and can track through tortuous epicardials. And then moving to the outcomes, basically. So technical success and procedural success was not different between the two groups. However, this came at a price of significantly higher peri-procedural complications. And in fact, these were mainly driven by perforation. So if you look at the perforation rate, it was about 17% in the ipsilateral group compared to 9% in the other group. Risk of donor vessel dissection, thrombus, and pericardiocentesis was also higher in the ipsilateral group. And then when we performed the multivariable logistic regression, we found that the use of ipsilateral collateral was independently associated with risk of procedural complication with an odds ratio of 1.7. So in conclusion, retrograde PCI through ipsilateral collateral is feasible. However, it is associated with a significantly higher complication rate, especially perforation. And in our opinion, this should be performed at a high volume center with experienced operators so that can deal with complications if they do arise. Back to our patient. So basically what we did is we consented him, we explained to him that this is a high risk procedure, especially if we end up using the collateral. We also made sure that we have the appropriate equipment, for example, coils in case we run into perforations and the wires and microcatheter. Then we tried antegrade first, which failed, and then we used the Caravel microcatheter as shown here to inject the collateral to understand the anatomy. And then on the right side of the screen, you can see the SUO3 wire successfully crossing that collateral retrogradely. Then after that, we performed a PCI achieving a nice result. And with that, I would like to thank the co-authors and the donors. Thank you so much.
Thank you.
Thank you for a very great presentation. It's very interesting. My question is for the ipsilateral,
Yes.
the 50% of patient is circumflex, and for the other groups is 70% is RCA. So do you think the cause of the complication that is different between those two groups is from the vessel itself because circumflex like more tortuous, something like that, or do you think it's from the technical expertise?
Yeah, so good question. So when we looked at actually the cause of perforation itself, which I did not show here, 40% of the perforation happened while crossing the collateral itself. And the rest happened in the CTO, like the target vessel. So again, more than half of the perforation were due to crossing the collateral. So I don't think it's the circ itself. I think it's just going through an epicardial collateral increases the risk. Part of it may be the circ, but I think to less extent compared to just going through the collateral.
I just follow up with a question.
Yeah.
Can you comment about the likelihood that you damage the collaterals and in fact make things worse in the process? Is that an issue to you when you're doing these procedures? And do you see myocardial infarction when you close a collateral accidentally?
Yeah, I mean, if you if you run into a perforation, then you have to coil these collaterals. And now it depends on if there is just a single dominant collateral supplying that territory or if there are multiple collaterals. So if, like in this case, for example, that I showed, there was a single dominant collateral. So you'll definitely run into ischemia. Now, again, patient will recruit other collaterals after you coil that, but yes, it is associated definitely with rise in like CKMB and enzymes in general and myocardial infarction for sure. Thank you so much. Thanks.
Our last, but not least, presenter, Dr. Athanasios Rempakos from Athens, Greece, working also in the CTO, chronic coronary disease arena. And we want to compliment you for matching at Beaumont and Royal Oaks, Michigan for your internal medicine residency. So that's nice to have this. And you're going to talk to us about predicting successful chronic total occlusion crossing with a primary antegrade wiring using machine learning. This is quite a presentation for 8 minutes.
Thank you very much for the introduction, Dr. Sharkey. And so good morning, everyone. My name is Athanasios Rempakos, and I'm very grateful for the opportunity to present on behalf of the Progress CTO investigators our work on predicting successful CTO crossing with primary antegrade wiring using machine learning. I have no financial disclosures. So in order to cross a CTO, we have 4 different crossing techniques. The simplest one is antegrade wiring, where we just advance a wire into the proximal true lumen, puncture the proximal cap, and then cross the lesion into the distal true lumen. Now we can also use antegrade dissection and reentry, where we instead go into the subintimal space and then re-enter into the distal true lumen. We also have retrograde, where we go through a collateral into the distal true lumen, then puncture the distal cap, cross the lesion into the proximal true lumen. And lastly, we have retrograde dissection and reentry, where we again go through a collateral into the distal true lumen, into the subintimal space, and then re-enter into the proximal space. Now, out of those, antegrade wiring is by far the most commonly used one. And there have been several crossing algorithms developed to assist operators in selecting the optimal initial crossing strategy. However, those rely on limited angiographic features, and they were developed according to expert opinions and not data. The aim of our study was to develop and validate a machine learning model for predicting successful lesion crossing using primary antegrade wiring during CTO PCI. We did that using the prospective global registry for the study of chronic total occlusion intervention, or Progress CTO registry, which currently has more than 15,000 cases at 67 participating centers from 10 countries worldwide. We used 12,136 primary antegrade CTO PCIs that were performed at 48 centers between 2012 and 2023. Data was missing for 8% of the total values, and we used Miss Forest to help fill in the missing values by predicting them based on the observed values of other variables. And this is a technique that has displayed good performance in mixed type data sets that include both continuous and categorical variables, just like in our case. Then features were standardized using Z-score normalization, which is a method of transforming data to a common scale, and this makes it easier to compare different sets of values. Lastly, we divided the data set into training and testing in an 80 to 20% ratio. We selected 14 variables for inclusion in our prediction model, and those were blunt nose stump, occlusion length, vessel diameter, aortoceal lesion, proximal cap ambiguity, instant restenosis, side branch at proximal cap, bifurcation at distal cap, poor distal landing zone, interventional collaterals, calcification, tortuosity, target vessel, and prior attempt to open the CTO. We assessed the predictive capacity of 5 machine learning classification algorithms, including logistic regression with L2 regularization, Gaussian naive Bayes, support vector machine, multi-layer perceptron neural networks, and extreme gradient boosting or XGBoost. Our outcome of interest was successful primary antegrade crossing, which was defined as successfully crossing the lesion using primary antegrade wiring. We assessed the internal validity using a stratified tenfold cross-validation procedure to get a realistic estimate of how those 5 prediction models perform, and XGBoost displayed the best performance with an average AUC of 0.775. But how does XGBoost work? So it starts off with a simple decision tree that makes a prediction for the outcome of interest. It then sequentially builds additional trees to correct the mistakes made by the previous one. So each new tree focuses on the errors of the combined model so far, and then their predictions are combined to get the final prediction. And we can think of XGBoost as a coach who watches the team play, notices where they make mistakes, and then figures out how to change their game plan for the next match so that they can win the cup at the end. Following hyperparameter tuning, which is the process of finding the best settings or hyperparameters of a machine learning model to enhance its performance, the AUC of the XGBoost model was 0.780 in the test set, and we had a decent calibration. Among the factors examined, occlusion length had the most significant impact on predicting successful primary antegrade wiring crossing, followed by blunt nose stump, interventional collaterals, vessel diameter, and proximal cap ambiguity. But how do we use this model in clinical practice? We created a web-based application to facilitate the convenient use of the model by the operators, and this is an example of how this works. This is the case of an 80-year-old man with medically refractory angina and 3 failed prior attempts for recanalization of a CTO in the RCA. His lesion had a blunt cap with a side branch at the proximal cap. Lesion length is approximately 20 millimeters and vessel diameter is 3 millimeters. And the lesion has heavy calcification, making this a complex lesion with a JSTO score of 3, which could make undergrade wiring crossing difficult. However, regarding collaterals, he has retrograde filling from the diagonal branch that is supplied by the lemma, which makes retrograde a high-risk option. So in summary, we have this patient with a complex lesion who at the same time has a high-risk retrograde option. So for cases like this, we can use the web application and input the lesion characteristics of the patient, and after hitting predict primary antegrade success, we can get the likelihood of successfully crossing the lesion with primary antegrade wiring. And for this patient, the likelihood was relatively high with 75%. So we decided to proceed with antegrade wiring, and the guy next to was able to penetrate the proximal cap, and then the lesion was subsequently crossed by using a Gladius Mongo. And this is the final result of the PCI. Of course, our study has limitations. It is an observational study without adjudication of clinical events by an independent committee. Core lab analysis of the study's angiograms was not performed. And lastly, the operators in the Progress CTO registry are highly experienced in performing CTO PCI, and this could potentially limit the generalizability of the study's results to centers that have less experience in performing CTO PCI. In summary, XGBoost was the best machine learning model for predicting primary antegrade wiring success with an AUC of 0.780, and the most impactful predictors were occlusion length, blunt nose stump, interventional collaterals, vessel diameter, and proximal cap ambiguity. And to our knowledge, this is the first model that accurately predicts primary antegrade wiring success. Thank you to the co-authors and the donors, and thank you for your attention. I'll be happy to answer any questions.
Questions? To go and learn my AI a little bit better, but that's a remarkable study. I congratulate you, especially to have other centers started using your application, I guess, to.
So it hasn't been published yet as a paper, so not yet, but hopefully in the near future.
And just because the length seems to be an important parameter, when you look across the, in the sphere of your work, how variable is the measurement of that parameter? And do you know the inter-observer variability, for example, in that particular? Is it difficult to measure, or is it fairly standardized?
So this is actually a good point. Thank you for that. So this is based on the operator looking at the angiogram, and this could potentially be a limitation. However, because most of the centers in our registry are very experienced with CTO PCI, I would say it's fairly standardized. So, but that's a great point.
Would impact kind of the readout or the prediction of success?
That's a great point, because as I mentioned, all centers in the Progress CTO registry have high experience. So I do believe that this could be helpful for an operator who has less experience in guiding them as to whether they should maybe use a proctor for that case or refer to a more experienced center. But I do believe that this is mainly to be used by experienced operators.
Thank you. Since we have a few minutes, and while we're waiting to see if there's any online questions, maybe I could ask each of you to tell us when your presentation is going to be and in what format.
So my presentation has already happened. We presented this in CTO Plus in New York.
Yes, we presented our data at the Tokyo Valves in February, and this manuscript is under revision now, and the revision has been submitted, so hopefully within a few weeks.
I'm going to present this in ACC this year. On the April 8th.
Yeah, we submitted the paper for abstract for CVI in Denver in July. Yeah, hopefully it will be accepted. Not yet, we don't know.
Yeah, so mine will be presented in ACC as a moderated abstract. Thank you. I don't remember the dates, to be honest. I have to look at it. Okay.
Okay. Thanks, everyone. Have a nice Monday.